Welcome, Dr. Itach.
Can you hear me now? Is it okay?
Yeah.
Okay. Great. Thank you very much. Okay. So my name is Tamar, and I'm a medical resident at the cardiology department of Tel-Aviv Sourasky Medical Center in Israel. And I will be presenting my work on prognostic implication of tricuspid regurgitation in STEMI patient. So this is my, it's not moving, I'm sorry. This is my declaration form, and I have nothing to declare upon. So I just want to go back to a little bit of history, the background of tricuspid regurgitation. So in the past, but not too many years ago, we used to believe that tricuspid regurgitation is an innocent bystander. As one can see, the paper of Nina Brownwald in American Thoracic Surgery in 1967 on conservative management of tricuspid regurgitation patient undergoing mitral valve repair, which conclude one can easily ignore tricuspid insufficiency when fixing the left-sided valve because it always goes away spontaneously. And that at the time, that was the common belief that tricuspid insufficiency is a benign condition that doesn't require any treatment. But then in the past 20 years, there's a growing numbers of work showing us quite the opposite, and that tricuspid insufficiency is not so benign as once thought to be. As we can see in the opinion article in 2010, the title was The Forgotten Valve, Lesson to be Learned in Tricuspid Regurgitation, which summarized a few important work at the up to that time. And I will present shortly one of them. So in 2004, Nets and al. Presented his work on impact of tricuspid regurgitation on long-time survival. This is a retrospective work on more than 5,000 patients, graded by the TR severity, and it followed them up to 4 years. And then what they saw, that according to the severity of TR, the survival was worse if you have moderate or above tricuspid regurgitation. And it was not, if we adjust it to LV dysfunction, RV dysfunction, age, SPEP, and so on, the survival was worse for patients with moderate to severe TR than those with mild or no TR. Another work from my department in 2020 for a bigger cohort, more than 30,000 patients, again, divided by the severity of tricuspid regurgitation. The follow-up time was 5 years. And we see more or less the same result. Patients with moderate to severe TR have worse outcome. They suffer from more heart failure, more readmission. The 30 days mortality is higher than 1 year, and overall mortality is a lot higher than people with no TR. So I think for now we can agree that tricuspid regurgitation is not an innocent bystander, nor is not a benign condition. But now we ask ourselves, okay, so what is the prevalence in the population of tricuspid regurgitation? How common is it? Then if we look at the Framingham study, which I assume most of us are familiar with, wide population study for a long period of years following this population. And in this paper, they present the valve disease prevalence. If we look specifically on tricuspid regurgitation, then we see that up to 80% of the population suffer from any severity of TR. But then we ask ourselves, okay, so how many suffering from clinical important TR, which is moderate and above? And if we look with increasing age, the prevalence of moderate and severe TR reached to, here we see up to 1.5% in men, this is the men table, and 5.6% in women, which show us it's not uncommon disease. And then another work by Tupilsky et al. In 2019, again, following a certain population in the Olmos County. And what he shows us here in the graph that if you follow this population and with age, the prevalence is rising. But also if you look on patients with other valve disease, such as aortic stenosis, mitral stenosis, AR and MR, then the prevalence of TR is even higher. And then in this another work that he presented with the title "Tricuspid regurgitation is a public health crisis." What he says that moderate to severe TR affects more than 1.6 million people in the US and about 3 million people in Europe. The problem is that we diagnose TR late because right ventricle can tolerate volume overload for many years. So people can be asymptomatic for a while at the presentation time, usually the severe is clinically important. And also we have low sensitivity for diagnosis with auscultation. So the main way we can diagnose it's with echo, but we do know that there's a wide underdiagnosis of valvular disease. So the number I just presented are probably much higher in the real life. And if we look at people that suffering from severe TR, how many of them are treated with surgical therapy, then we see that only 5% are going through repair or replacement. So what we can say that TR is definitely a common problem, health crisis problem, and most of the people are underdiagnosed as well undertreated. So just go briefly of etiology to tricuspid regurgitation. We usually divide it to two main groups. So the first one is the functional TR, which means that the TR is secondary to another etiology. If it's the left-sided heart valve, the pulmonary hypertension, either right ventricular dysfunction, and so on. And this is the main group. More than 90% of the patient will be functional TR. The other one is primary TR, and that's due to congenital disease or due to infection or endocarditis, as we can see here. Also flail or coaptation of the leaf plate. People suffering from carcinoid, people who went through chest radiation, and people with pacemaker. This is important etiology because we always need to remember once we implemented a pacemaker lead in the right ventricle, then TR is something we need to consider and we need to look for. So a lot of questions arise whether the worst outcome for tricuspid regurgitation patient is due to the main etiology causing functional TR, and that whether people with only isolated tricuspid regurgitation are not suffering from the same prognosis. So Tupinsky again show in 2014 that people with isolated tricuspid regurgitation with no other valve or heart disease, if we follow them for several years, we can see that people with severe TR are suffering from lower survival rate and higher cardiac event. Therefore, their prognosis is not good or better than people with functional TR. All of that led us to ask ourselves, okay, so we do know that tricuspid regurgitation is something we need to consider, but what is the prognostic implication of tricuspid regurgitation in STEMI patients? So in the present study, we investigated the clinical profile in hospital outcome and long-term mortality associated with the presence of TR in STEMI patients treated with primary PCI. This is a retrospective single-center observational study for 2,139 STEMI patients admitted between September 2011 and May 2016. We excluded patients with missing records of tricuspid valve echocardiographic evaluation, as well patients with previous MI or previous TR, which was already known about. And therefore, the final cohort consists of 1,071 patients. The mean age was 61, and 80% were male. What we did is patient presented with STEMI went through primary PCI if the patient were with symptoms up to 12 hours or up to 24 hours if they were still symptomatic. All patients went a screening echo examination within 6 to 72 hours. TR severity was determined using the American Society Echocardiography recommendation, as we see in this table, but I'm not gonna go over it. And in our study, we had 32 patients diagnosed with moderate to severe TR, while the rest, 1,039, were diagnosed with either mild or no TR. And this is the baseline characteristic in this table. And we do see that patients with moderate to severe TR were significantly older, as well, more female gender, suffered from more hypertension, and had lower kidney function. But the rest of the baseline characteristics were not significantly different. If we look at the echo parameters, then we see that it's mostly different. So if we look at the moderate to severe TR, then those patients significantly had worse echocardiographic parameters. They had lower ejection fraction, they had higher septal E prime, they had enlarged right atrium size, they suffered from higher S-pipe, but I do like to mention that there was no significant difference in TAPSE. If we look at the in-hospital outcome, then patients with moderate to severe TR had higher 30 mortality rate. If we see here, it's 12.5% compared to only 2% with patients with no or mild TR. They also suffer from more acute kidney injury. They needed more hemodynamic support or mechanical ventilation. They had more heart failure and arrhythmia and major bleeding. Okay. If we want to look at the long-term outcome, then we follow this patient for a mean period of 2.5 years. In the entire cohort, 6.6% of the patient died, but mortality was significantly higher among patients with moderate to severe TR, 28%, compared to patients with no or mild TR, only 6% of this group died. And that was, of course, statistically significant. So looking at this result, we ask ourselves whether the difference between the two groups was due to the difference in baseline or echocardiographic parameters. So what we did is a multivariate Cox hazard analysis, and we adjusted for significant clinical and echocardiographic parameters. And mortality hazard ratio of moderate to severe TR still remains significant after adjustment. So we think we can conclude that moderate to severe TR can serve as a prognostic marker in STEMI patient, but we do have to bear in our mind a few limitations of the study. Once it was single center retrospective and non-randomized observational study, the moderate to severe TR group was small, patients were significantly older, female gender, and with lower kidney function. And also, we only included patients with first MI with no previous TR, and therefore we cannot generalize our result to all STEMI patients with tricuspid regurgitation. So to conclude, I think that now we can say that the tricuspid regurgitation is not forgotten anymore, but not forgiven. TR adversely affect prognosis, and among STEMI patients, moderate to severe TR can serve as possible prognostic marker. To our knowledge, this is the first report to data suggesting a possible prognostic implication of TR in STEMI patients. I do want to thank you all for listening, and if I would like to use the remaining time for questions.
Thank you, Dr. Itach. That was an excellent presentation. Hope the participants have learned and benefited by sharing your view. Does anyone have a question?